it's Casey here. I put up a LinkedIn post this morning just saying how we increased our health assessment utilisation through our nurses, something like 140% over the last 6 months. This is mostly on the back of how we've changed our care plan process. So I want to talk about that in this video today. I'm going to look at the screen and sort of go through how we did it. So this is our old process here, right? Essentially, we just had, doctors would identify patients, send them to the nurse, that do the care plan. Same for health assessments. We found that just created a huge bottleneck being, the nurses, because we had one group of nurses that would do both of these things, plus doing their, wound dressings and procedures and all sorts of things. So it's a huge bottleneck. And we found that if anyone was ever sick, that we would almost seem to pull them from our CDM first. The CDM would go off and do the wound dressings if the wound dressing nurse was sick or something like that. And we just found it created a huge bottleneck. Nothing was getting done, and certainly not to the level that we wanted to do it. Then the care plan changes came along, as you're probably aware. They got rid of the 721, 723, which was a big lot of value in terms of finances that was dedicated towards paying the nurse. So we thought there's got to be a better system here, especially in the context of the new care plans, 965, 967 being a fair bit more streamlined. So streamlined in the context of there's just less MBS requirements. So in terms of the MBS requirements, obviously you've got a chronic condition, etc., that the patients need, so diabetes, things like that. Now, for further information on MBS, I do courses with the Business for Doctors. They do BFT education, they do an MBS weekend. I teach at those. They're a great thing to get to in terms of the specific requirements. In this video, I'm just talking about the actual logistics of how our patient flowed through our clinic. So old way, huge bottleneck. We just had the nurses, and really this should be one box with this going up here and then this coming down here as well, because it's just the one nurse that did sort of everything. Look, we don't have the funding to do the nurses with the care plans now because the value's been significantly decreased. So what is a system that we can do where we're doing just as many care plans, and this is something that we tracked with our analytics and data capturing to ensure that we were doing the same number of 965, 967 compared to 721, 723, 732. The main way that we did it was actually through artificial intelligence, through AI. We found that because of the streamlined nature of the care plans, essentially what we could do is we could get a doctor to see a patient and do a care plan in the appointment that was comprehensive. The SMART goals had tasks, etc., and we can do that really, really easily. What that then allowed us to do is push health assessments more to the nurses. Now, in terms of how to increase billings, I've got that other video on what we focused on in terms of increasing billings and sort of and frameworks around that. This was all about leverage. So how can we leverage the doctor's time? We want the doctors to be doing the most valuable thing. The most valuable thing is seeing patients. Now, in my other video, when we did talk about recalls, previously that was a sort of a doctor-driven or doctor-led process. And I sort of thought to myself, I think it'd be better off if we had the doctors just seeing patients instead of doing recalls. So we pushed that one off. We got the nurses to do a system really sleek, but it meant that doctors could just focus on what they do best, which is managing patients, seeing patients and doing that. So same sort of thought process behind this framework, being that we thought nurses can do health assessments. Health assessments include nursing time, and therefore there's a lot of leverage there that we can get with the nurse time being added to the doctor time. We then thought, due to the nature of the MBS requirements of a lot of health assessments, we can pull other items out of them. So care plans, medication reviews, and then of course your 10997s. So we'd send the 10997s, we'd send the care plans back to the doctor for them to do. We would send referrals off to our HMR. We've got a combined referral process for those. So just the one email address. We've got about 4 or 5 pharmacists operating that. And then we've got our health assessments. So you're over 75, etc. And we thought that was a really good process because even if we had junior nurses that were not as proficient and quick at doing a health assessment, that was okay because their time counted towards the overall item that we could charge in the context of a 701, 35 or 7 because they're time requirements when you add in the doctor time. So we thought overall that process worked for us. So that allowed us to increase our health assessments by hundreds of thousands of dollars over a 6-month period. I think it's 150 grand. So a significant increase. This is for our time-based health assessments, I should say. For our 715s, which are slightly different, we'll do another video. We did a slightly different process, but again, just looking at how can we leverage the doctor's time. With care plans being not timed requirement, doctors can do those quickly. That was leveraged, but with health assessments having a time requirement, we got the nurses involved with those, and that seemed to work really well. So hopefully that's made sense. Thanks for watching, and I'll make some more videos. Cheers around. Bye.